Hello everyone, this is Rafael. I'm one of the chief residents at Mount Sinai West Morningside, and I'm going to talk to you a little bit about malignant pericardial effusion as part of our oncological emergencies curriculum. Since we are talking about emergencies, we're going to be talking about tamponade, which is compression of cardiac chambers secondary to fluid in the pericardial sac. What is the emergency? As you know, tamponade is potentially life-threatening. Why are we talking about this in our oncological emergencies curriculum? Well, the reason is malignancy is the most common cause of pericardial effusion in the developed world. Approximately one-third of the cases are caused by malignancy. When it comes to clinical presentation, I just wanted to briefly mention here the tumors that are mostly associated with pericardial effusion and tamponade. Those are the ones in the chest, so breast, lung. You can also have melanoma through metastases. There's also a primary tumor of the pericardium. Mostly it's mesothelioma, but it's very rare. And I just wanted to mention that cancer patients can have effusions due to other reasons that they're predisposed to, such as immunosuppression predisposing them to purulent infections and radiation therapy predisposing them to pericardial scarring. So these are just some other things to keep in mind. And when it comes to the clinical presentation itself, we all remember Beck's triad, hypotension, elevated JVP, and muffled heart sounds. However, it does not typically present. More likely, you'll have a patient with shortness of breath and chest discomfort. Symptoms are more likely to develop if the effusion develops rapidly. However, you can have a hyperacute presentation in a patient with a chronic effusion, just given the last drop phenomenon. And you can have EKG with electrical alternance, tachycardia. Pulsus paradoxus is an ominous sign, and it usually only develops later on. As part of the workup, you have EKGs, TTEs, chest x-rays. You can also have CAT scans and MRIs. Just those are usually to look for pericardial scarring and just basically pericardial disease itself as a potential cause for pericardial effusion. Now, here is an EKG. You can see that the patient is tachycardic, like we mentioned, and it shows the typical electrical alternance, which is basically a change in amplitude of the QRS from one QRS to another. So you can see here just how it changes from one beat to the other beat, and so on and so forth. So for TTE, you're going to see right atrial compression as the first and most sensitive sign, just because it has the lowest pressure out of the chambers of the heart. However, right ventricular collapse is more specific. You might also see bowing of the interventricular septum towards the left ventricle during inspiration, just given the right ventricle doesn't have much room to distend to the pericardium. In chest X-rays, you might see the water bottle sign. Of course, we're not talking about fancy modern Brita water bottles, but we're talking about the older, more water bags, really. The you can see here in the chest X-ray that it is likely filled with the pericardium is likely filled with fluid. When it comes to the management, if your patient is hemodynamically unstable, of course, pericardiocentesis with ultrasound to guide it. And the issue with malignant pericardial effusion is that it is more likely to recur. So many attendings will just prefer to place a drain as initial management. You can also have a pericardial window or even pericardiotomy to prevent recurrence. Adenocarcinomas are more likely to recur. IV fluids can help if hypovolemic. As you might remember, IV fluids will help the preload of the heart, and it will help with kind of compensate the compression of the pericardium. And if you're dealing with a malignant pericardial effusion, then of course treating the underlying malignancy is the main or most important management going on. However, just do it if compatible with patient goals. The reason why I specify this, it's because malignant pericardial effusion carries a very poor prognosis. Some studies have shown a median survival of around 5 months, and about 80% of patients die within the year. So just keep this in mind and make sure that you're also treating the patient, not just the disease. And just some of the take-home points, like I mentioned, it is usually an indicator of poor prognosis, and just keep it in the differential if you have a patient who is hemodynamically unstable and has a diagnosis of cancer. And these are just the reference that were used. Thank you, everyone. I hope this was useful.